Go ahead and start. Yeah, great. So it's my pleasure to welcome everyone to the Center for Addiction Medicine and Policy Speaker Series. We do this every other month, late in the day on a Thursday. And the idea is to get our multidisciplinary groups together on these important topics and bring in experts to so we can learn from, and then hopefully, kind of rapidly transition to thinking about how to implement in our setting. So today, it's my pleasure to introduce Dr. Bill Soares, who's coming from University of Massachusetts, and both is a researcher, clinician in emergency medicine, and the director of their harm reduction program. So I'll turn it over to you, Bill, and we'd love to make this really interactive. I see such great people with a lot of experience. So we have time for questions at the end, but you can also raise your hand. We can manage the chat and interrupt if necessary. So go ahead, Bill. Thank you.
Great. Thank you so much for the introduction. I appreciate it. Let me share my slides real quick. All right. And please do interrupt. We'll try to take a few breaks to allow for questions so that it flows. And what I'll do is I'll try to leave the chat box open on the side window here. So if you see me looking to the side, it's a separate screen and nothing else. But yes, as Jean Marie mentioned, my name is Bill Soares. I am the Director of Harm Reduction Services in the Department of Emergency Medicine at Bay State, and an assistant professor at the UMass Medical School, the Bay State campus. And today I'd like to talk to you about a program that we've started, expanding medications for opioid use disorder, methadone in the emergency department. Some disclosures, this is my funding through NIDA, but I have no other relevant financial disclosures. So a little bit about me and my family. Nice to meet you all. We've been living in the Pioneer Valley of Massachusetts for about 9 years now, ever since finishing residency. For those that don't know, we refer to the Pioneer Valley as just outside of Boston. We refer to most things in Massachusetts that are not Boston as being just outside of Boston. These are my kids. This is the top of Mount Tom overlooking the town of East Hampton. Interesting, fun things about the Pioneer Valley. So one, it was the home of Dr. Seuss, and it is thought that this mountain and this overlook was the inspiration for the Grinch, that the Grinch was overlooking East Hampton or Whoville. So you can see some of my kids are appropriately grumpy after climbing, much like the Grinch. We also, for younger kids, the home of the Lunch Lady series.
How's my boss going to tell me?
And for those of us who are still old kids, Northampton, which is the town next to us, happens to be the home of the Teenage Mutant Ninja Turtles. So I'm not trying to recruit people to Pioneer Valley, but we do have a lot of cool things here. I've also, for the past 9 years, worked at Bay State Medical Center. Bay State Medical Center is located in Springfield, Massachusetts, which you can see from the star up there. It's the academic tertiary center. It's about a 700-bed hospital, and it serves the surrounding area. With regards to the surrounding area, so you know where we're coming from. Springfield has a population of about 150,000. It's the third largest city behind Boston and Worcester in Massachusetts. It kind of has a common story to a lot of Massachusetts cities. It was a booming manufacturing town, and then when manufacturing kind of went under, it got hit pretty hard. Springfield itself, you can see from the map, is actually divided into neighborhoods. So there are 17 different neighborhoods. And unlike the rest of Western Massachusetts, it is racially and ethnically diverse, with this being the makeup of our population. If you happen to visit Springfield, there are some few interesting things. So we are the home of basketball. It was created at Springfield College, and you can go to the Basketball Hall of Fame. There is a Six Flags, which has still today one of the scariest roller coasters I've ever been on, the Superman roller coaster. And interestingly, a few years ago, somehow we got a casino. And I know that's probably a whole other area of research that maybe people are into there. I don't know how I feel about it yet, but it is there. Unfortunately, it's different for the people that actually live in Springfield. And I want to tell that story a little bit. With respect to some of the determinants of health, so you can kind of see the base of where we are. In Springfield, the median household income is about $30,000. and that's less than half of the median household income for the rest of Massachusetts. About a third of Springfield residents live below the poverty line, and about half of kids in Springfield live below the poverty line. With respect to education, over half the residents have a high school degree or less. And as you can see from the graph, it's disproportionately less in our Black and Latino populations. Some other things, although it is racially diverse, and none of the rest of Western Massachusetts necessarily is, and it actually is one of the most segregated in the US for Latino Hispanics, and the 22nd most segregated for Blacks. Housing, about 51% have housing cost burden, defined as spending more than 30% of your income on housing. And most of the population lives greater than a half mile from the grocery store. So I imagine there are folks who live and work on this call who have similar populations that we treat. And, really it's these health disparities as well as many other factors that have really contributed to the severity of opioid use disorder in Springfield. This is a graph of the 5 largest cities in Massachusetts. And you can see in the red line, Springfield has been the only city to have consistent increase in opioid overdose deaths per population over the years. And in fact, in 2020, we surpassed other cities in our death rate in Massachusetts. Massachusetts already being a high rate of opioid overdose and opioid use disorder. It is really an important topic. As was mentioned, I work in the emergency department, and working with patients who have opioid use disorder is a daily occurrence for us, as I think it is for many of you as well. To give you some numbers with regards to our emergency departments, these are ICD-10 diagnoses for patients who presented to the emergency department and were documented to have an overdose or withdrawal. And this is by month from 2019 to 2021. You can see if you add up to, we see anywhere between about 40 to 60 or more patients per month. And these are only the patients who the provider has recognized and documented as their primary diagnosis, an overdose or withdrawal. You can imagine we see many times more who have other diagnoses, psychiatric diagnoses, medical diagnoses, who also carry opioid use disorder. So this is really something that's prevalent in all our lives in our folks that work in Springfield. Now, what has that led to? We've really worked over the past 5 years to try to create programs to address this. And really the goals of those programs have been, at their base, is to recognize opioid use disorder for the emergency medical condition that it is, and for our emergency providers to kind of change from simply treating patients who have opioid use disorder to treating patients for their opioid use disorder. And I know for some in the addiction field, this may not be new, but for those of us in emergency medicine, this has been a pretty drastic change. I didn't graduate residency that long ago. It was about 10 years ago. And I remember being told that this is not something we do, right? We don't address chronic problems. We treat if they have an emergency and send them out. So this paradigm shift of really trying to understand that this in and of itself is the emergency. So within that, we have different programs. We have a safer usage program, which includes take-home Narcan. It also includes, we directly distribute syringes and syringe disposal units from the emergency department, fentanyl test strip, and other safe usage supplies. We do our best to engage in post-ED follow-up. Post-COVID, that is a lot of telehealth follow-up, usually with bridge prescriptions and linkage to community resources. We've also really tried to work to integrate into our community through collaborations, obviously, the research, but also the task force representation to be out in the community and try to do primary prevention, as well as making sure people are connected to treatment. But really what we're here today to talk about are some of the medications for opioid use disorder. I think many of you know or have experienced that this also has been a change, the incorporations of medication for opioid use disorder in emergency departments. And like many others, we have a few different programs. We have buprenorphine inductions that happen in the emergency department. People come in withdrawal and we start them on bup. We have folks that are not ready to start in the ED, and so we do home inductions, usually through prescriptions and follow-up. And then we have take-home bup kits made for those who don't have access to insurance or otherwise wouldn't be able to get their buprenorphine, where they can actually leave with 5 days in hand. These programs are about 4 years old. To give you a sense, about 90% of our adult emergency attendings are waivered. And we have about 2 to 3 ED BUP inductions with discharge home per week that we manage. And that was kind of going all well and good. And then, about last year, it felt like something changed a little bit. And this is an actual case that I had. I was actually, during this case, walking out the door to go home and was stopped and say, hey, could you help me with this person? It was a 55-year-old opioid use disorder for years. He injected about 3 to 4 bundles per day, which is about standard for us. We do have a very high prevalence of fentanyl. I think just like, unfortunately, most places now, we're at least 90%. I don't know that there's heroin actually out there anymore. Attempted to stop cold turkey, presented to ED in withdrawal, seeking help. He was shaking, nauseous, moaning. Unfortunately, he was in our hallway. It was a very busy day, but you could see he was clearly in distress. I went to talk to him. Last use was 24 hours ago. For me, this is the perfect buprenorphine patient, right? He denied any other drug use. It seemed like, this buprenorphine was hopefully going to make him feel a lot better, and we were going to be able to get him onto treatment. We give him bup, and in fact, at that point, we had transitioned to more high dose bup. He was really in distress, so we started with 16 milligrams. And so I go home thinking that, this was a consultation. My shift had ended. The resident and the other attending are going to take care of him. And then I get a call an hour later saying that he's worse, right? That he is not better. He feels worse. And that's odd, right? He should be the perfect. He meets the time frame. He meets the COWS criteria. Like, what did we miss? What's going on? So I said, look, 16, maybe he uses more than that. Give him an additional 8. Let's try to power through. Let's see if we can get him stabilized and through what I think is precipitated withdrawal. So we give him an additional 8. And it doesn't necessarily make him worse, but it doesn't make him better, right? It's not the classic case that we all see of they come in awful and they're just feeling a whole lot better. So what should have been a quick, hour, get you feeling better, get your bup, get you out, turned into multiple hours of some Ativan, some clonidine, some Zofran. And unfortunately, he left, maybe a little bit better, but not much better than when he came in, with the fixed belief that, buprenorphine or Suboxone was never going to work for him, that doesn't work. And my providers, we all left, kind of with hesitation, right? This should have worked. We made someone feel worse. And so I don't know with some of those providers what's going to happen with that next person. This has happened to, I would say more than a few times with us, and I know it's something that other people are experiencing. These are a few of the case reports and other challenges in this, what they're calling the era of the fentanyl overdose crisis. And I have to say, I don't know. I know your group has started to do some research. Is this fentanyl? Is it the lipophilic nature? Is it polypharmacy? Is there something else in the drug supply? I don't know whatever is causing this, but what I do know in our community, it doesn't happen that often, but the perception among our persons who use drugs is that if you use a lot of fentanyl, bup or Suboxone is not going to work for you. So what that is translated into is people are less interested in starting bup, and people have become more hesitant. So that was one thing, and I'm happy I can stop there to take if there are any questions, or I can continue. I didn't see anything in the chat.
It might be a time I would just globally echo exactly that. We are trying to adjust the starting dose to, is it 1 or 2 milligrams, or is it 32 milligrams? Is it big dose? Is it small dose? I think both the evidence and theory is all over the place, and we have not found such a solution. I have recently shifted to thinking that 16 milligrams all at once for patients who are in withdrawal might be more effective. But that you just shared, one more anecdote that that fills my armamentarium to just say I'm just not sure.
And I believe you and I think Austin, I had talked to before about looking at urine fentanyl and things like that. It is a question, and this is besides the talk. We've talked about, do we bring back urine tox screens, not for the fact of judgment, but for the fact of, let's just see, are people, we do have a lot of diverted methadone. Are people getting methadone and they don't know about it? Is there something else? But even there, it's limited, right? Our urine tox screens that we have in the hospital. So Hopefully this is something we can shed more light on, but it is the situation that we and others, I think, are dealing with right now. At about the same time, from the research aspect, we were actually doing qualitative research looking at patient perspectives. And this is a paper that just got published, a qualitative paper looking at patient perspectives of starting medications in the emergency department. We interviewed 26 participants with lived experience. 50% had used unprescribed opioids within the last 6 months, and 25% were classified as more active users they used within the past week or even within that day. They were pretty experienced with medications, like most of our patients. 88% had tried bupe, 73% had tried methadone, and 69% had tried both. The interesting thing about this study is when we designed it for bupe. We designed it for what do our patients with who are experiencing opioid use disorder know about bupe in the ED? What do they think about bupe in the ED? And the interesting and unprovoked thing is when we started talking about bupe, their natural question to us was, well, what about methadone? And I have a few quotes from folks. So for Suboxone, you have to be able to be clean for 2 days, and none of these people are going to be able to do that. I have all the hope and faith in everybody, but it's just not realistic. So I'm always recommend going to methadone first because you can still use while you're on methadone. And for a lot of us, that's really important. There's no wake-up call, light switch moment. It's sort of a fluid thing. And even if they're not ready to stop, methadone might keep them alive until they get to that point. Or it might, like me, make them get to that point. So that was one, I think, powerful view. Just to note, we had some other opposing views. Participant L also said methadone is literally one of the worst ideas in the entire world because you could still use with no repercussions. So it's not to say that it was the panacea of methadone, but people were asking about, when we started to say we're offering treatments, they wondered about different treatments. And actually, all of us in the research group really liked this quote, and it actually became, part of the title. Just give them the choice. I'm an advocate for both buprenorphine and methadone. There's so many different pros and cons, and I just had to figure out which one was more suitable for me. It just all depends on your situation and you and where you are in your life, which one's better for you. So it really was those two things, right? Listening to people and getting their perceptions of what should be offered, and the fact that we were having more difficulties, that we really started to explore methadone as a potential option, a low barrier ED methadone induction protocol for our patients. I will quickly, I know for most of this will be a very basic review, but for anyone just in 2 slides who maybe is not quite as familiar with methadone, it's a full opioid agonist. It's the only other approved opioid agonist for the treatment of opioid use disorder. Oral peak effect is 3 to 4 hours. And one of the things about methadone is the long variable half-life, up to 60 hours, which largely means that stabilization of the serum methadone level takes time. The graph is representative of that it takes that time, somewhere between those 5 to 7 days. And others with much more experience can please correct me if there's anything different. Compared to buprenorphine, when we think about it, they're looking at studies. The efficacy is similar, if not a little bit better, maybe just for the point that it has been around longer and studied much more extensively. For some, there's advantage of daily frequent provider check-in, especially those that are unstable. Importantly, from our standpoint, there's no risk of precipitating withdrawal given the agonist, and there's no ceiling effect. Some of the disadvantages that I think about as an emergency provider, unfortunately, it's still very highly stigmatized, even more so for us than Suboxone or buprenorphine. Obviously, it cannot be prescribed. And, unfortunately, there is an asterisk here. If I put methadone on a prescription and I say this is for pain, then it can be prescribed. The law states that it cannot be prescribed for the treatment of substance use disorder, which, again, there are still a lot of antiquated laws and regulations that can go into methadone. It must be administered through a licensed opioid treatment program, OTP, which we'll try to use, but the other, we also think about methadone clinics, but we'll try to say OTP. Obviously, just like we talked about, it can take some time to reach stable dosing. There is the risk of oversedation, especially with aggressive dosing, and obviously overdose, especially when combined with other medications. And then as the dose gets higher, becomes the issue of potential QTC prolongation. That's all I'll say about that. I think most people know much more than I do about methadone on this call. So what I really want to do is mostly go through our steps to implementation and talk about our initial experiences, because although methadone has been around for treatment of opioid use disorder for many, many years, it has somewhat been siloed, right? And we'll talk about this, when we asked emergency providers about methadone, there's not much knowledge there. And when we asked about protocols and what we can and can't do, we really kind of started from the base. So the steps that we did, well, first we asked, can we actually do this? Is this legal for us? Because our knowledge was that methadone has to be administered through the OTP. We then wanted to assess, okay, maybe it's legal. Will our emergency providers and will methadone clinics, will they actually buy into doing this, right? Are we going to get big pushback or other reasons why this can't be done? And then some issues of creating IT infrastructure and obviously education and dissemination. So let's talk about the legal aspect. This is the kind of important slide, and I copied it verbatim. It's a bit full, but this is the entire Title 21 CFR 1306.07B, which seems to be the important key portion. This subset of the Code of Federal Regulations deals with administering or dispensing of narcotic drugs. And it says, nothing in this section shall prohibit a physician who is not specifically registered to conduct a narcotic treatment program from administering but not prescribing narcotic drugs to a person for the purpose of relieving acute withdrawal symptoms when necessary, while arrangements are being made for the referral for treatment. And then it goes on and says, not more than 1 day's medication may be administered to the person or for the person's use, and such emergency treatment may be carried out for not more than 3 days and may not be renewed or extended. And that is it. That is the total. There is no further explanation. There is no explanation of terms, as much as we asked other legal folks. But it gave us a sense of, there is, this clause in the regulation and administration of methadone that basically says that someone who is not a registered narcotic treatment program can administer these drugs for relieving acute withdrawal symptoms in the process of getting them into treatment. So we took that and we passed it by a few different folks. First, our own hospital and legal compliance. Second, we actually talked to our Bureau of Substance Abuse Services to make sure that there was nothing else that we were missing. And it was a great call, because I was prepared to make an argument for this. And basically they were like, that's great, you just do it. But they didn't offer much more as far as being able to explain, because there's nothing much more in the law. Nobody knows what is meant by some of the terms. I was also lucky enough to connect with Dr. Jessica Taylor, who's pictured here. She's the medical director of the Faster Paths Bridge Clinic. We were looking for other programs that we could draw off of and work together with. And we didn't find too many, at least in our area, that had been doing this on an outpatient basis. Dr. Taylor, though, had started this actually a few months before and had come up with a protocol for an outpatient bridge clinic, and actually a 3-day induction protocol, and then referral to the methadone clinic. So we were able to kind of compare notes and think about what was the legal aspects. And actually it was nice, because it went through 2 legal departments, hers through Boston Medical Center and ours through Bay State. So it provided some additional reassurance that we could do this. I'll stop there for a second on that. If there were questions or thoughts. Otherwise, the other aspect that we always hear about, and I think as emergency physicians, it's kind of the boogeyman in the room is, CFR 42 Part 2, right? Oh, what are you going to do? CFR 42 and things like that. CFR 42 deals with the disclosure of substance use disorder patient records, and can be kind of this stop when people hear they have substance use disorder. What can we do with their information legally? And for this, when we looked at this, I have to credit SAMHSA. I've included the web link below, but they have a great PDF that basically walks through and says, who does this apply for? And for those of us who are in the outpatient world, and the ED is considered outpatient, if you go to scenario 4, the integrated care settings, it talks about, because the primary function of the outpatient unit, meaning our ED, is not to provide a diagnosis, treatment, or referral, the ED itself is not a Part 2 program, and these enhanced consent processes are not applicable. It doesn't mean that we don't treat patients with substance use disorder, but our primary function as an emergency department is to be an emergency department, not to be a substance use disorder treatment center. So it was thought, from this and in talking with others, that we would be able to transmit information. We would be able to refer information to the OTP, which was a critical aspect of being able to connect people. Obviously, standard HIPAA practices and compliance still applied. And obviously, as we'll get into later, CFR 42 applies the other way. So although I can transmit, it is more difficult for me then to get back information about that patient and their treatment in the clinic. I don't know if others have more experience or any comments on that. I have a question in the chat about the protocol. I will, in a few slides, we'll break down the actual protocol itself, so folks will be able to see it. So we thought we cleared the legal barriers, and we thought it would be technically possible. We didn't know if people would buy into actually doing it, both our ED providers and our OTP clinicians. So from a larger sense, from a research aspect, we actually designed a qualitative study. So we sampled from medical providers around Massachusetts, and we ended up with 25 medical providers that provided interviews, 10 from academic EDs, 6 from community emergency departments, 8 who were the medical directors of OTPs, and 1 who was a medical director of an OTP and then also worked as an inpatient addiction medicine physician. They were from across Massachusetts. We used a code book. We used CFR, the Consolidated Framework for Implementation Research. And just quickly, we are actually still in the process of kind of finishing these results. But initially, they were very interesting. So when we think about some of the facilitators and barriers, overall, people were willing to hear about it, right? No one started off saying, no, this is wrong, I don't want to do this. And especially from an emergency department standpoint. And I really want to credit the folks, especially that have really worked on this, your group and other groups, all the ED physicians that we talked to were willing to engage patients with opioid use disorder. And I think that's a big change within the past 10 years. There's recognition that it is a disease process and we need to do something to help. Now, there's still a lot of ways to go with many people, but just the recognition that, okay, I'm willing to hear this out and consider this as a treatment option was really heartening. Having peer champions helped. Really, what they wanted was a clear and easy protocol. They wanted ED providers, like many things, wanted it to pass the night shift test, right? If I'm seeing a patient at 2 a.m., does this protocol work? There were some barriers that ED providers identified as we were creating the protocol. There was a lot of lack of experience with methadone. Most people only used methadone if someone came in and missed a dose, and they would verify and give that dose. Otherwise, there was almost no use of methadone and people weren't familiar with it. Because of that, there were concerns of safety. And obviously, for many things that we deal with, concerns, can we actually get them into follow-up? From the OTP provider's standpoint, all thought that it was feasible. And interesting to me, they thought that having clear, safe initial dosing guidelines, which we'll talk about, but basically starting doses of 20 and 30 milligrams for folks with diagnosis of opioid use disorder would be safe and could really reduce the harm of people not being able to access treatment. The barriers they identified, again, can we coordinate care? Can we how do we meld together the hours of the emergency department versus the hours of the OTP? And then how do we comply with some of these structures? We are presenting more of this. If folks, any emergency medicine folks are coming to SAM, we'll be there and we can talk more. I will stop with my shameless plug. From the ED itself. So we looked overall and did a research study, and that was great to look at overall sentiment. But thinking back to where we're going to implement this, I am very lucky to have co-champions. And these are folks, attending physicians, who really believe the fact that opioid use disorder is an emergency in harm reduction. They have been the first in line with the take-home Narcan, with buprenorphine. When we first started distributing syringes, they were first in line for that. And they've been first in line to really consider adopting methadone. And really it has been, without them, being one person or two people, trying to convince a staff of many would be overwhelming. But having other co-champions there who can be those initial people, who can give honest feedback about how that process really has helped. We are also, like many places, we're lucky to have an amazing group of residents and advanced practitioners who, many of them, part of the reason to come to a place like Bay State was to serve that population in need. And even working a few shifts, recognizing that this is a major health problem, they've really been willing to engage patients in treatment, which has been excellent. And finally, and we're going to talk about this maybe in a little bit more depth, is really a critical piece to this for us has been the relationship with the OTP. We are very lucky to have two very strong advocates, Dr. Ruth Potee and Dr. Neil Lackritz, who are the clinical directors of our opioid treatment programs in Springfield. And part of the reason, going back to that matrix there, part of the benefits of being involved with the community, even before we started talking about methadone, was the fact that we had already worked together on other projects. So when we approached them to say, hey, this is what we're encountering, we're thinking about, can we feasibly start methadone and refer to you, and they can continue that, they were really supportive. Partly, I think, because they trusted us, because we had worked together and we had demonstrated that we can diagnose opioid use disorder, that we can reasonably assess a person, that we can get them to where they need to go. So we'll talk about that in some of the next slides with the specific protocol. But it really is, when we think about how does this work at other places, because of those regulations, really the relationship with the OTP becomes critical to the function. So this is the protocol. For folks, I put up a QR code if you would like the entire protocol. The entire protocol is like 20 or 30 pages. For those who may be unfamiliar, take your phone, put it onto picture mode, and just put it over the QR. You don't have to take the picture. It should pop up with a Google Drive that should give you access to the full protocol. What we're going to go over is the flow diagram, which summarizes pretty well. It doesn't get into all the details, but it'll give you a good summary of what we had developed. And don't worry, I'll make each of the boxes a bit bigger. So let's start with first, is this person a candidate? And remember, this is based on, we have to follow federal regulations. So they have to meet the inclusion criteria. They have to be 18 years old or older. They have to have a diagnosis of opioid use disorder or be diagnosed with opioid use disorder. We ask that they have opioid use within the past 7 days. It can't be someone who had opioid use disorder 3 years ago. Importantly, they have to have a symptom of opioid withdrawal. Now, this is where the benefit of being vague is a benefit, because there's nothing in the law that says what is opioid withdrawal. So we have defined that as a COWS greater than 0, which technically, if you have a COWS greater than 0, you have opioid withdrawal, which we all know from the COWS score is rather flexible. So we are using that and making sure to define that as that we are treating active opioid withdrawal. Obviously interested in methadone, and that also means knowing that they are, if they're interested in continuing treatment, that at least for the foreseeable future, they are getting daily dosing at the OTP, valid photo ID. Some of our contraindications, the isolated accidental overdose, we put this in because we see this. Unfortunately, we have a high incidence of pressed pills and people thinking that they are buying something, and it turns out not to be. And we just want to remind our providers that that does not necessarily make a diagnosis of opioid use disorder. End-stage liver disease, altered mental status. With regards to prolonged QTC, if they have a history or on multiple medications, we encourage an EKG. But I think, as many of you are aware, the prolonged QTC really is not something that happens until you get to the higher doses of methadone, not something that we're dealing with. And when I talk to our OTPs, they don't get a baseline EKG on most of their people. That's something that happens as the dose increases. So we're trying to keep this as easy as possible and saying, look, you as a provider, if you want to get it, great. But if they have no history and they're not on multiple QTC prolonging medications, it is not necessary. to do that. So the next step, if they meet those criteria, we have some documentation. Most is to actually help our OTP to understand them a bit more. Some basic things about their history of opioid use, and also any prior methadone use. Have you been to another place? When was the last time? Again, to kind of help a little bit with that intake process. We have an automated form which was already created where nursing can document the cows to make sure that cows is documented as above 0. With regards to labs, so we don't require any labs. And that is for a specific situation, and that is for patients who have obvious stigmata of recent opioid use. So this was something that I learned, and others probably know well. In the OTP, our OTP directors were saying, we get urine toxicology because anyone can come in and say they have opioid use disorder, and we need some sort of confirmation that they actually have opioids or opioid in their system. The emergency department is a bit different in that most of the people that we see have obvious stigmata. They have an opioid related or an injection related injury or illness. They've had an overdose. They're in clear withdrawal. And we all know that, especially in the ED, that urine toxins and others can be somewhat stigmatizing. So we came to the agreement, look, if they have obvious clinical stigmata of recent opioid use, right? They have opioid use disorder, they obviously have been injecting, they're coming in with an overdose or something like that, then it's not necessary to make them hang out for an extra 2 hours and confirm with a urine opioid test. You can treat them, they have the diagnosis, they have signs of recent use, and you can start medication for them. But if they don't, if someone was just walking in saying, hey, I want methadone, they would need to have some sort of confirmatory. I'll hold there for a bit and just see. That was an interesting part for me as an emergency physician that I didn't think much about. And feel free to write in the chat as well if.
I think this is pretty, we kind of do something similar, but we have not tackled the handoff. So we can treat opioid withdrawal with methadone, low doses of methadone in the ED, whether the patient is starting or is going to be admitted or discharged. But we haven't really worked at all on the handoff part, primarily because we didn't understand how to do it, and we haven't smoothed it out like you've done. So this is great, and we don't really require a tox screen to do it. Like you said, we recognize OUD and people who need treatment for their symptoms.
Yeah, no, that's great. I had a question in the chat, which is great, that asked, urine drug screens are stigmatizing. That is a great point. For all the work that we've tried to do, I would say it's the ED that is stigmatizing. The ED is still, even for us, is a hard place for folks with opioid use disorder. And I think making it, and we take a lot of effort to try to build that trust, because probably by the time they come to us, it's been broken, right? Whether they got too much Narcan, whether they heard a comment from someone on the street or law enforcement or EMS or some of our staff, where they're, for us, they're placed in the psychiatric unit, because for some reason that's where we place our post-overdose patients, not in the medical unit where they should be, but with the psychiatric patients having acute psychiatric crisis. So all of those things add up to, it is trying to build some of that trust. And I think part of that, urine toxicology for us has a history of being judgmental. We as emergency providers used it to prove that, hey, you're lying to me, right? You were sleeping, you said you didn't do anything. Oh, look, I got your tox screen back and it had this in it. So it's more the history of how we've used it. I don't think by themselves. And we actually have a few clinics that use the buccal swab, but we don't have the buccal swab for the drug screen. But yeah, so that's why we initially avoided it. We may talk about, with this whole issue with precipitating bupe, just having the drug screen just to see more for when, we may be able to safely prescribe bupe, depending on what research shows.
I didn't mean that to be negative. I just thought it was just kind of funny in a way, because you're worried about the UDS results, but you're going to give them methadone, which in itself I think is much more stigmatizing than a than a urine drug screen. Sorry.
No, not at all. It's a great point. And I think it's the difference. And it's just understanding that as emergency providers, unlike folks who have worked in addiction or other spaces, we are still a place that needs to gain trust of people.
You guys have a very tough job. So this is, I think, is great. And I'm in Philly, and we work with a couple of the different hospitals, and they get the okay to start people on methadone and titrate them up and discharge them directly to us because they're in there for obvious things, infections. But
yep.
Sorry to interrupt your talk.
No, not at all. Thank you for doing that. So once we do that, what is our dosing protocol? Again, we tried to keep it simple. We realized that providers, as an individual provider, they're not going to do it potentially that much. So there's basically two protocols, 20 milligrams or 30 milligrams PO. And that's based on their self-reported use. If they use less than a bundle, or they've never used methadone, or their dose was less than 50 milligrams, then we start them with 20 PO. If they inject inject more than a bundle, snort more than 2 bundles, or have been on methadone and their dose was actually higher, then we start 30 PO. There is the option that we give, especially if they're in withdrawal, to wait a few hours and then give an additional dose. We do have a stop of 40 milligrams per day as that initial dose, which I think many places do. And that's consistent somewhat with the OTPs and what they were comfortable with as well. So someone that got 20 that's in severe withdrawal, they may get a couple more doses of 10, but they're going to stop at 40 for that initial. So that's all easy. And that's actually nice because for the emergency provider, that's pretty straightforward, right? Do you want methadone? Do you apply? Let me document some things. Let me get you a dose. Where things come in is actually on the discharge, and we worked hard with this. So our OTPs agreed to a guest dosing protocol. So imagine, someone's admitted to the hospital, they're seen by the addiction medicine clinic, they're started on methadone, just like you said, they're stabilized at a dose, they get out. For our place, and I think it's true for other places, the methadone clinic will say, you have been started, you have been stabilized, maybe you're out on a Friday and you're coming to the clinic Saturday. We are going to continue that dose until our provider who comes in Monday can see you, assess you, and then we will assess changes in the dose. That's currently what happens with our addiction team for patients that are inpatient in the hospital. We basically took that and shortened it and said, in the OTPs said, why don't you do this? Start with the dose, send us the appropriate paperwork, which includes our consent form, signed last dose letter, face sheet. We will have that information. It can be faxed 24 hours. The next day, we're open 7 days a week. They will get it. They will understand this person is coming in. That person is coming in. And if the provider is not available that day, they enter into the guest dosing pathway. So they will continue on their last dose for us. Now, we are lucky in that our clinics right now have really been supportive and have agreed and have pretty decent coverage. For the most part, 5 days a week. They're able to get seen. And because this is a new program, they really try to get folks seen so that they can start to adjust those doses. But this is a limitation for other places. This is unfortunately why some of our community hospitals, we haven't been able to figure this out because, for example, one of our community hospitals, there's no methadone clinic. They would have to travel 30 miles to get to the methadone clinic. So it has both been a good experience for us, but it also is a potential barrier for others. But that's the key portion. It means that this protocol is 24/7 because we send to a secure fax and they are getting that information in the morning, and then that person shows up and they are immediately in that guest dose. So they are, for intensive purposes, guaranteed you got 30, we will get you 30 today. And if we can't see you tomorrow, you get 30 tomorrow. And then, usually by then they are able to be formally intaked into the methadone program. There were a couple things that popped up. So a couple of good questions. The 20-30 milligrams initial dose, have those been effective? So that's interesting. So Jess Taylor, who I mentioned before, the Bridge Clinic really is a walk-in for substance use disorder. Their numbers are so much higher and she's had more experiences. She is finding in that population, which is kind of the Mass and Cass Boston Medical Center, really the part of Boston that really suffers from opioid use disorder. She is actually her 3-day program. So she brings people in and starts them usually for 3 days until she can get them into the clinic. she has mentioned bumping up to 40, 50, 60 because those initial doses aren't covering as much. And I don't know, you all probably have more experience with that. We will see in some of the results, we, are still in the early stages and haven't had much experience. And we've been lucky that our OTP providers can see them pretty quickly and start to bump them up. So no one sat at 30 for, any length of time. But eventually that could be a concern that we actually need to increase. And maybe, it's 30, 40 instead. And then pharmacy gives issues. Pharmacy in general won't if it's 30 or less. When we hit the 40, they somehow have a mark and it just needs to be talked. It's an individual pharmacy thing. And we just say, look, we are doing what is the max daily dose of 40 milligrams for us. Go ahead.
Do they bug you for EKGs on everyone also?
They don't. Yeah, they don't. And then we leave that to the discretion of folks. We do have a lot of people who have comorbid psychiatric conditions. So, and the EKG is not invasive. So oftentimes we'll have it, or we'll have an old on the person that we can check, but they don't. To finish up, so we also, because we realize that folks are busy and they're not going to do this too often, we created an IT infrastructure. So we use Cerner, and this is the power plan, which basically just has all the orders clicks away. Which makes it hopefully easier for our providers. Includes the naloxone kit from the Pyxis. It includes a consult. So actually, I get this page. It has to change from buprenorphine to substance use coordinator. Our IT has been busy with other things. But it means there's a backup where we get pages through our system to know someone has been started. And then there was education. We did a very nice, I had just watched Encanto, which if any of you have watched it, it is amazing. And we did the talk with the residency about we don't talk about methadone and tried to present the protocol for folks. So to give you an idea, we were in the pre-implementation phase. We started about September, maybe end of September. And really there, we were making sure things worked because we didn't want to roll things out and realize no one's getting that fax, or the methadone clinic is, refusing people, or we're doing it wrong. So what we did with our kind of co-champions is we really limited and said, look, talk to me. Let's talk about the patient. Let's walk through the steps. And then we're going to follow up with that person to make sure it works. We had a few cases. It seemed to work fairly well. And then we did the education and bumped it up to full implementation in December. So let's talk about a little bit of where we are. So I'm going to say 10 patients. It is actually, and I'll talk about one of the challenges, it's actually hard to figure out. Patients are fluid. We've had patients who have started on the program and then something else has come up. Maybe they came in for an abscess and it was a little bigger, or they developed a fever and they needed to be admitted. So the actual denominator, although we thought it'd be easy to capture, has been a little bit more difficult. We have a lot of patients who come in with psychiatric complaints as well. And sometimes that disposition of, oh, they're going to go home, we're going to start them on the methadone protocol. Oh, no, wait, they're coming in inpatient. And then it falls out because then they go through the inpatient process and hopefully continue methadone. But of those, we have had the majority who have had next day OTP follow-up. The folks that have went to the places that we sent them directly to, we know that the 4 of the 10 continued for greater 2 weeks, and many are still on and engaged with methadone. Again, this is an issue, and this gets to 45 CFR because I can't go calling the other methadone clinics and say, hey, have you seen this person? So if anything, hopefully this is an underestimate, and none have returned requesting additional methadone doses to the emergency department. Our challenges, I'm going to highlight you all because I really refer to your study about sustained implementation, because we are really in that implementation phase. And to think about, what are those low numbers? Are they low numbers? We do promote buprenorphine first because from the aspect of ease of use, it is a lot easier, right? We can write a prescription where our typical prescriptions are 7 days. I can contact them via telehealth and I can extend for multiple days. I can deal with insurance. I can cover them. Methadone in this is much less forgiving. I have only up to 3 days, and most of the time it's 1 day of being in that clinic and trying to get them then connected to. But thinking about what can we do to improve implementation. The patient follow-up piece has been a bit more challenging than we thought. And that again is just, we are able to give information, but the sharing of information back to assess outcomes was, a bit more challenging, and we have to adjust. And then, although we haven't had patients return for dosing, the hard part about the language is that it basically says in the law it is not to be reused ever again. I should say it is not to be renewed or extended. We don't know what that means. Does that mean it's not to be renewed or extended in their lifetime? Does that mean it's not to be renewed or extended in this period of treatment? So there's not much there, and we're trying to come up with what that means in case that comes up. But a last slide. And I really like this because it gets to the overall aspect of harm reduction. It's hard to see who exactly was in the ED discharge methadone program, and that has been a little bit tricky. But we basically pulled, well, let's just look at overall how much are we administering methadone? Because part of it is trying to teach people that in the emergency department, opioid withdrawal kills, right? And that, I think, is one of the biggest fallacies that I've encountered, one of the biggest changes, right? Again, 10 years ago, opioid withdrawal doesn't kill, alcohol withdrawal kills. But in fact, opioid withdrawal kills, and we all know this because opioid withdrawal means that they are going to leave, that they are going to use, and that has a very high mortality rate. So part of this, and I've highlighted our pre-implementation phase in yellow and our implementation in green, it is nice to see that the overall numbers of times we are administering methadone to patients in the emergency department is increasing. Now, maybe that is starting people on methadone. Maybe that's the fact of just asking and verifying their dose and understanding that someone waiting for 3 days for a psych eval really needs their methadone dose and really doesn't need to wait multiple days and suffer in withdrawal. Maybe that means, as you mentioned before, understanding they're going to be admitted and giving just a dose of methadone. So when the hospitalist sees them the next day, they're not in fluid withdrawal and wanting to leave AMA. So there are some encouraging signs that I think our providers are getting more comfortable overall with methadone, and this obviously needs kind of further breakdown and evaluation. Interestingly, I'm sure many of you heard in March, there was a memo from the DEA expanding access to the, unfortunately, that they still use the term medication-assisted treatment. But the idea was that now for medications such as buprenorphine, but also for methadone, that it could be administered as a 3-day supply. Still not prescribed, but for the treatment of substance use disorder, you could actually potentially have a methadone starter pack that had 3 days, which is a change. We don't know how this changed and exactly how potentially it will work, and it's still very early, but it is something that we've kind of started conversations about. For us, really our emphasis now is really on implementation. And then from the research standpoint, it's really trying to study this, working and looking for collaborators, because I really like that we are doing it. I think if we want other people to do it, we need to show that it's beneficial to patients. And so, for me, I'm in the point of transitioning from the K08 to R01s and really trying to look, can we design studies that both help patients, but also show that this works, or show that it doesn't work, so we can really potentially start to disseminate. That's all I have. Thank you for your time. Contacts below, please contact me. I'm happy to stay and answer questions. I know there are a few questions in the chat, so I'll get to those right now. I got one from Kit. Initial dose is 20, add 10, had similar experiences of a total 30, not improving symptoms. Yeah, we haven't had folks in such florid withdrawal. We've had folks, so one of our patients was in a moderate, I think he had a COWS of like 12, and he used enough to get the 30 initial and then the additional 10. And we may have given him some other comfort like a clonidine as well, but he was pretty stable when he left. Our thought has been, if we've given 40 plus some comfort meds and they're still unstable, then that's going to be admitted. We just don't want people to leave feeling that amount of withdrawal, knowing that they're going to have to go out and use. They're not going to be able to be that uncomfortable for a while. And then,
so I don't know if you want to stop sharing just so we can have a little more discussion.
Yeah.
If everyone got, you can otherwise email us for your contact info, but just so we can chat a little bit more. But thanks for that really thoughtful presentation. I think there's, it's like you said, a few more questions in the chat, and then I have a few too.
Sure, I'm happy to. So just looking as far as wounds or infection, typically with this, if patients are being admitted to the hospital, the emphasis has been on let's give them that initial dose still, and then we have that button to automatically consult the addiction consult service, which hopefully next day can up titrate. Part of it, the way we've explained it to the residents is similar to insulin dosing, right? If someone has a painful thing, if they came in with broken ribs and they're going to be a trauma admission and they have substance use disorder, opioid use disorder, you could try to catch up with, dilaudid Q whatever hours. But really, if you can provide a basal rate and then PRN is needed. So we've talked about give the 20 or 30, you're still maybe going to need to give PRN, but hopefully that's going to lessen the frequency and the intensity that you'll need the PRN medications for them. So we haven't gone to higher than 40 and explored that at least through the ED, but we have said if they're painful conditions, it's a little easier. Unlike buprenorphine, where then you battle the partial agonist, it's a little easier to do that. And then there was a question about Ubering folks. We don't transport them to the clinic. We are lucky in that our main clinic is in a central location. But we definitely in Springfield, there are issues with access. There's issues with access, there's issues with phones. Transportation is a big thing. And insurance, in Massachusetts, we have universal insurance, but unfortunately, if you don't have an address and you miss the mailing, you can get bumped off. And we struggle with that a bit. It takes a little bit of time to reactivate.
I say one quick question. I guess maybe two questions. One, I'm trying to figure out which one should I ask first so that you could answer it and get to the second one. But so I was taught that 10 IM or 20 PO treats all opioid withdrawal in the heroin era. I know that we've gone to higher doses now, but I don't really see people with cows of 10 or 15 after methadone doses of 20 or 30. I hear them saying a lot of complaints, but I don't see the objective withdrawal as much. And I wonder if there's a component of xylazine, factor in there. I know we hear this a lot on the inpatient side. That's a complicated question. I don't even expect an answer. But the other question that maybe you could answer is buprenorphine. What has the methadone option done to your buprenorphine initiation rates? Because that's my concern. We were really trying to get people on bupe, and if we offer them both, I think it'll just be so easy to solve the acute problem with a full agonist, and people will defer, bupe to some later date.
Yeah, no, it's a great question. I feel like in a year we're gonna know more. We have not yet had people coming back and saying, hey, you gave me a methadone dose. Can you give me a methadone dose again? I think overall, again, thinking about harm reduction, my main goal for a lot of these folks is to even just get them connected. I'm lucky in that one of the two methadone clinics is a combined methadone Suboxone clinic. So even if this is someone, who wants Suboxone, but is not ready and is really in a bad place, if I can stabilize them and at least have them make contact with that clinic, then a single dose is not going to prohibit them from having a Suboxone induction in a place that's a bit more kind of controlled and organized than the emergency department. Part of the reason we don't know is because the Suboxone inductions went down before because people were refusing and we had nothing. We were just saying, you don't want Suboxone, here's harm reduction things, here's options in case. So I don't know. And the other thing is a lot of folks, I shouldn't be surprised, but surprisingly have good knowledge of what they want. Most of our folks have tried medication, and unfortunately, because of issues with our accessibility, have tried diverted medication, right? They've tried Suboxone from someone, they tried 40 of methadone, they liked how this worked, they didn't. 2 years ago, they were on Suboxone for a year, and that worked pretty well. So oftentimes we're mostly using there have been very few. In fact, there's been no one that we've had who started on methadone who has not tried anything. Almost all of the folks have said, and this is part of the reason, that they tried Suboxone, had a bad experience, and they don't want to do that again. So I think potentially having that tier and explaining to folks, because I don't want to put the stigma in my favor, but it is a burden to say you're going to have to go every day to the clinic and show up and wait in a line for a second. People like the idea of a prescription and being able to manage that. So we haven't yet seen that, but it will be interesting to see as it becomes more available if that does change.
That's great, thanks. And just, did you partner with one program initially, or did you partner with several? So I think we'd want to start with one just administratively, but
yeah, we partnered with one, and then we had, I forget what wave of COVID, where we really started to have layoffs, and unfortunately that impacted the OTP and their capacity went down a little bit. And then we had really had the other OTP, and they had actually opened up, not only they had the Springfield branch, but they actually opened up in the neighboring town of Holyoke. And so we have worked more recently with the other OTP because their capacity. But it's an unfortunate question. The protocol only goes so far as the OTP can go. If they hit capacity, if they lose that capacity to see people, there's not other options that we have. So it is something that we're constantly evaluating and realizing that we're lucky again in that we are pretty stable and expanding our OTP access where we are, which is a good thing. But other places that may not be the case.
Jean Marie, what state are you guys in?
we're in Philly, Pennsylvania.
Oh, no, yeah, send them to me. Send them to me. I'm in Philly. Send them to me.
We're planning on it, Dr. Bob.
Yeah,
I
I was
That's why we
gonna
invited you.
ask,
That's
actually,
planning
for
on
all
it.
the people who came through our late invitation, email us, and we're going to get a meeting together with your group, Dave Malloy, you, anyone else associated with a methadone program in Philadelphia. We will meet and chat about this exact thing. So I appreciate you coming, and I appreciate us directly learning from Bill today, because this is really helpful.
What he's doing is fantastic, and I wish more places are doing that. But like, send him
I know
here.
we have capacity locally. I know that's not really a problem.
I'll
So
take
it's really been, the hiccup of us getting this together.
And I know from the standpoint of the OTP, Ruth, you mentioned Jean Marie, Ruth Potee has been a big advocate, and she definitely has the viewpoint of when they come into her from the ED, and maybe won't say to me, but can definitely talk about some of the issues maybe she's had with the ED and otherwise. So for folks from that aspect who are wondering some of those other issues, she is a great resource. And then Jess Taylor, who her experience with this, because it is a dedicated substance use clinic, and she has experience with the other aspect of the law of not having methadone on site. So having to deal with, how do we legally have methadone at our outpatient bridge clinic? We didn't have to do that. And I know she worked hard to get that done.
So their clinic should set up a satellite clinic at your location, because that has been, it's available since the summer, I believe. So you can have mobile methadone or non-mobile structure setting mobile. So whatever, like in your hospital, I could set up a Meraki satellite for people in Philadelphia. I don't know if I can go up to Massachusetts or wherever you're at, but I mean, like there are these new little things that no one has capitalized on yet. But take home message, what you guys are doing, Bill, is great, and I'm very impressed that you're being so forward thinking. It's awesome. But for the folks in Philly, if you call me, I will do my best to help the person out. And that's why I asked about the Ubering and things, because Dave Moy has a team and they get everyone to us. But unfortunately, not everybody gets. We're not made aware of people coming in a lot of times, and our staff gets to them and kicks them out first.
I was going to say, one of the big challenges is the coordination between the medical side and the social service side. So like we've been trying to do this for 2 or 3 years now. And, I'll get a doctor on the horn at Temple or at Penn or wherever, and they'll be like, all right, let's do this. And then somewhere in there, the ball gets dropped, like with the coordinator. And then I'll get a phone call. This is always my favorite call, aside from the I got a guy calls that I get from Nicole. We'll get a call on like a Friday at 4:15 in the afternoon. Hey, Joey Potatoes, he's leaving here in 45 minutes. Can you dose him? It's the coordinating, and hopefully, I just want to throw it out there that we work a meal into whatever meeting we're going to have, and include cake, because a lot of things get accomplished over meals. I'm just throwing it out.
But what they have there for the weekends, which was probably what you're referring to, is Bill has a setup which I actually like, and I'm actually comfortable doing it. If they give somebody methadone and Saturday, I'm probably not going to be here if I don't have to be, but they could get dosed with continue the dose that they started there. I actually like that. And, that's a trust relationship you have with that director and clinic there. But, I'm pretty stupid and I trust everyone. So I say we try the same thing,
And we are trying, I think it's a good point, David. Even before this, we tried to emphasize to folks, as you get the folks who maybe were a psychiatric evaluation and are discharged at 10 in the morning, and the instructions of, just go over to your clinic, and understanding that, especially at Springfield, that is harder to do. So taking that time and saying, look, it's kind of my responsibility to make sure if they're in the hospital that they get their dose that day. We've tried to emphasize it. That aspect can become hard as far as verifying. We do allow up to 40 milligrams of unverified. And that, that's just been kind of our protocol for that.
If someone's actually using it and they're only taking 2 or 3 days of 30 or 40, you're probably not going to kill them anyway. So, like 2 days on the weekend, if I got any kind of habit, and it's all predicated on fentanyl now. So, if I use fentanyl for 3 days and you give me 30 milligrams, I may catch a buzz, maybe. I don't know. You're probably not going to kill somebody. And that would be the bigger concern, like the Saturday, Sunday unseen type thing. But, the reality is, at least in Philadelphia, most people are frequent flyers and they're all well known and established. So I think that I'm okay coming in on Saturday and Sunday, but I'd rather be at home and, being lazy. But I think using that with that setup you're doing is fantastic. And, I'm very impressed. And,
Yeah, and we had a lot of discussions. I didn't talk about that, but what we're giving them a full agonist. They just overdosed. Like, what is the danger of that? And I think ultimately it was weighed against the danger of, we know from prior research, as soon as they walk out, right, it's within that first day, there's about a 1 in 400. And it doesn't seem like a lot, but the amount we're seeing, right, it has to be weighed against the idea that if we don't engage them, they are going to go out and use, and there's inherent risk in that itself. And so
you can give them the full agonist, the FDA approved safe medication, or the bag they get from Poppy or whoever on the corner out there that is unknown, because they're going to either one. It's going to be either one. And I'm not big on harm reduction, but I am big on harm reduction, but that's a great thing to do. I'm glad I tuned in for this.
Thanks. So thank you, everybody. I appreciate your time, Bill, and I know we all learned a lot, and we have an opportunity to do some implementation work on our end. So we'll keep you posted. Look forward to seeing you next week and your presentations there. So thanks, everyone. Thanks, everyone, for your time. Enjoy the beautiful evening. See you next time.
Thank you, guys.